A vision in healthcare is a promise about who will remain well, who will receive care, and whether the system will be strong enough to serve the next generation. Here across the Gulf, we hear the language of Vision 2030, Vision 2035, 2040, and even Health Vision 2050. The ambition here is absolutely unmistakable. But these labels don't all describe the same kind of document, the same stage of reform, or even the same type of operating model. And that distinction is actually what matters. A national vision can certainly set the destination of where we want to be, but a health strategy is what actually creates the route. An implementation program can change how care is actually financed, regulated, and even delivered. A scorecard can tell us whether any of it is improving people's lives. Welcome to Health Majlis, conversations shaping healthcare across the Middle East. I'm Dr. Paul Setlak, and in this solo episode, we'll look across all 6 GCC countries: Saudi Arabia, the United Arab Emirates, Oman, Qatar, Bahrain, and Kuwait. What we'll do is clarify what each country has actually established in terms of a vision, why its model matters, and how healthcare leaders, innovators, and investors can apply these visions responsibly. This absolutely is not meant to be a ranking. It's not meant to be a contest in the language of ambition. It's a comparison of different ways to turn public purpose into daily delivery and impact. The question I want us to keep returning to is actually quite simple. What changes for the patient here in the Middle East? Before we move country by country, it'll really help to read these frameworks in 4 distinct layers. Layer 1 is the destination. This is the national vision, the kind of society and economy the country here wants to build and the place health occupies within it. Layer 2 is the route. This is the sector strategy or policy, meaning the priorities, outcomes, and principles that should guide health system decisions. The third layer is the delivery machine. Who regulates this? Who purchases? Who provides? How are the primary care hospitals, digital platforms, public health, and the private sector all connected together? This is where an elegant strategy meets institutional reality. And layer 4 is the actual scorecard. What is the baseline we're working with? What is the target? Who owns it? When will it be reported? Without that layer, activity can easily be mistaken for impact, and it just becomes an academic exercise. This framework also protects us from 3 common traps. The first trap is treating a new building as a health outcome. Infrastructure may be essential, but a hospital opening is not the same as earlier diagnosis, safer care, or a healthier population. The second trap is treating technology as the strategy. An app can certainly create a useful digital front door, but it doesn't automatically produce interoperable records, redesigned pathways, trusted clinical decisions, or the ability to harmonize data. The third trap is using the word alignment too loosely. Saying that a proposal is aligned with a national vision is easy, but showing the patient group, the pathway, the accountable authority, and the measurable outcome is definitely much harder, and actually much more valuable. Patients don't experience an organizational chart. They experience whatever they can find the right entry point, tell their story once, move safely between services, understand the next step, and receive follow-up. That's the practical test we'll use throughout this episode. So let's begin with Saudi Arabia. The correct hierarchy or term we use is Saudi Vision 2030, with the health sector transformation program operating as one of its vision realization programs. It's more accurate to use that terminology than to invent a separate title, such as Saudi Health Vision 2030. The program's 4 official objectives are to facilitate access to health services, improve their quality and efficiency, promote prevention, and certainly enhance safety. Importantly, access is not treated as a single idea. It includes things such as capacity, geographic reach, timeliness, and affordability. The system is still in transition. The Ministry of Health is moving towards a policy oversight and regulatory role, which is key. The health holding company provides public care through 20 health clusters, which are progressing through a staged journey towards accountable care. The published future state architecture assigns the funding role to a national health insurance function. Why does that matter? Because it changes the unit of accountability. A hospital is accountable for an episode of care. A population-based cluster can be accountable for the health needs of people across prevention, primary care, urgent care, elective care, chronic disease management, and actual follow-up. Saudi Arabia's model of care reinforces that direction through 6 integrated systems of care, including preventative care, urgent care, elective care, safe childbirth, disease, and palliative care. The patient shouldn't have to act as the project manager between those services. The official 2025 program reporting points to the scale of progress. Health services were reported to reach 97.5% of populated communities, and life expectancy was reported at almost 80 years against a program ambition of 80 years. These are important signals, but they are program-reported outputs and outcomes. They shouldn't be turned into a claim that every region or population has had the same experience. We don't see that across healthcare anywhere. But for healthcare organizations and partners, Saudi alignment therefore means more than locating a product inside a hospital or integrating a new one. It means identifying the cluster or population need, the relevant system of care, the access or outcome barrier, and the way the intervention will integrate with things such as data, workforce, and financing. The most useful question is not, how innovative is this? It's actually more of who becomes accountable for a better result, and can that result be measured? Saudi Arabia's transformation is not simply a hospital building program. It's an attempt to redesign who regulates care, who purchases it, who delivers it, and who is accountable for the health of a defined population. The United Arab Emirates requires a little bit of a different lens. There's no single currently published healthcare-only document that's formally titled UAE Health Vision 2031. But that doesn't mean the country lacks any sort of health direction. In fact, quite the opposite. It means that the direction is distributed across a federal umbrella, emirate-level strategies, and targeted national policies. So at the national level, we have the UAE 2031, which places health within the Forward Society pillar. Its stated ambition includes better health services, readiness of facilities and professionals, being a leading destination for medical treatment, and a place among the world's top 10 for healthcare quality. The National Strategy for Well-Being 2031 adds a wider lens across physical activity, mental well-being and wellness, and also quality of life. At the sector level, the Ministry of Health and Prevention's 2023 to 2026 strategy describes a world-class health system for a community with long, healthy life expectancy. It focuses on integrated sector organization, proactive high-quality care, professional and private sector governance, and stronger public health and prevention. Then comes the federal structure. The ministry provides federal stewardship. The Department of Health regulates Abu Dhabi. The Dubai Health Authority governs and regulates Dubai's health sector, while Dubai Health operates as an integrated academic health system. The UAE Health Council provides a coordination layer across federal and local bodies. Each emirate can move with its own priorities. Abu Dhabi currently frames those priorities around a healthy population, access and quality, and a resilient, efficient system. Dubai combines an end-of-cycle health sector strategy for 2022 to 2026 with the longer Dubai Social Agenda 33 and a major healthcare expansion plan through 2033. And, as we discussed in Episode 2, Law Number 17 of 2026 established the Dubai Longevity Authority, the DLA, as a specialist regulator for longevity, wellness, and advanced health sectors. Now, for the patient, the architecture becomes tangible through information. The National Rayadi platform connects with Abu Dhabi's Malafi, Dubai's NABIDH, and Emirates Health Services Warid. The promise is continuity, a more complete history, fewer unnecessary repetitions, and a safer handover across organizations. The patient should not have to understand the architecture for the architecture to actually work. The importance of the UAE model is that it can support speed, specialization, and experimentation. Its corresponding challenge is coordination. Common data, comparable outcomes, clear accountability, and the correct regulatory route. For a healthcare partner, the first question should therefore be jurisdictional. Is this a federal policy issue, an Abu Dhabi regulatory issue, a Dubai delivery issue, or a program that crosses them? The second is interoperability. The third is evidence: can the result be compared across settings without flattening the differences between them? The UAE does not lack a health vision. It implements one through several connected layers, complex layers, and its coordination capability is itself part of the strategy. Recently, Oman offered one of the clearest examples of layered planning across different time horizons. Oman Vision 2040 sets the national destination and calls for a leading healthcare system with international standards. Health Vision 2050, first published in 2014, remains a long-range health planning reference. It hasn't been made redundant by the National Vision. Absolutely not. But the National Health Policy launched in 2025 then defines the current principles under the theme Health for All, by All. And the 11th five-year plan for health development, covering 2026 through 2030, is the present implementation cycle. So in other words, Vision 2040 sets the national destination, the 2025 policy defines the rules of the journey, and the 2026 to 2030 plan organizes current delivery, while Health Vision 2050 keeps the longer horizon visible to everyone. The policy direction here includes an equitable, transparent, and accountable system, sustainable with diversified financing, qualified national talent, research combined with innovation, technology-enabled care, and stronger prevention. It also reinforces primary care, emergency preparedness and response, pharmaceutical and biotech security, and a One Health approach that recognizes the connection between human, animal, and environmental health. Geography is especially important. A national health promise has to be meaningful across governance, not only in the largest urban centers. Decentralization can bring decisions closer to local needs, but only if standards, data, workforce, and accountability remain connected nationally. Oman also uses healthy life expectancy as a long-term test. from a stated baseline of 65.6 years in 2016 towards 67 by 2030 and 70 by 2040. Healthy life expectancy is not just simply about living longer. It asks how many of those years are lived in better health, similar to what we talked about in the last episode. So for partners, applicability begins with place and population. Which governance? Which underserved group? Which part of the pathway? What local capability will remain when the project ends? How will the intervention support, rather than fragment, the national architecture? Oman's lesson is the value of continuity. A long horizon is useful only when successive policies and plans stay connected to it in alignment, and when each planning cycle leaves the system more capable than it found it. Qatar provides a particularly clear vertical line of sight. Qatar National Vision 2030 sets the destination through 4 distinct pillars: human, social, economic, and environmental development. Health sits within human development with an ambition for a comprehensive, world-class system that is accessible to the whole population and balances prevention, treatment, research, workforce, and sustainable funding. The third National Development Strategy for 2024 to 2030 is the final medium-term implementation strategy for that national vision. Beneath it, the National Health Strategy 2024 to 2030, called Health for All, provides the current sector roadmap. Its 3 priorities are improved population health and well-being, excellence in service delivery and patient experience, and health system efficiency and resilience. Now, these priorities are translated into 15 outcomes across prevention, integrated care, experience, research, digital capability, and financing, amongst other areas. And the strategy also states 3 headline 2030 targets. First, a life expectancy of 82.6 years, a 36% reduction in mortality from non-communicable diseases, and lastly, infant mortality of 2 per 1,000 live births. A target doesn't prove success in advance. What it does is make ambition testable, something to strive for. It creates the basis for asking whether resources, pathways, and partnerships are moving a population outcome rather than simply generating activity or buzz. Qatar's strategy also makes patient experience part of the performance story. Now, that's important because technical quality and lived experience are not 2 distinct competing ideas. A safe service that's hard to navigate, poorly explained, or disconnected at handover is not an excellent system. For innovators and industry, the golden thread creates a disciplined application test. Which of the 15 outcomes does the proposal serve? Which patient pathway changes now? Which measure should move or should not yet? What evidence is required and to what degree? Can the solution work with national data standards, clinical workflows, and also any type of financing constraints? And what burden does it place on the workforce? Qatar's Developing Health Technology Assessment Capability, HTA, is a good example of the next step, moving from enthusiasm for technology to transparent decisions about clinical, economic, and social value. The lesson from Qatar is simple. Alignment becomes more credible when there's an unbroken line from national purpose to sector outcome, provider planning, and patient measures. Bahrain's overarching destination is Bahrain Economic Vision 2030, built around sustainability, competitiveness, and fairness with a higher standard of living for its citizens. Its National Health Plan 2016 to 2025 has now completed its stated term and effect. In June of 2026, its cabinet approved a successor, the National Health Strategy for 2026 to 2030. The public announcement describes some further development initiatives, but doesn't yet provide a full detailed public target table. So we should recognize the successor without assigning any specific goals yet that haven't been published. The most visible reform logic is the Sehati model. It's a national insurance program designed around the Shifa purchasing fund, greater autonomy for public providers, and a national health information infrastructure. This is not simply about giving someone an insurance card. It changes who purchases care, how money follows the patient, how providers are governed, how claims and information move, and where accountability sits. At the primary care level, the model includes registration with a health center and family physician. This is intended to strengthen both continuity and referral coordination. The intended patient value is a clear entry point and better navigation. The intended system value is more disciplined purchasing, greater visibility of resource use, and clear provider accountability. But choice has to be made real. A theoretical choice of family doctor has limited value if the information doesn't follow the patient, if capacity is uneven, or people just don't understand their coverage. Financing reform, service design, and even digital infrastructure have to move together in some level of alignment. For partners in Bahrain, the practical questions are, therefore, which of the purchaser-provider relationship changes? What information is required? How does the proposal strengthen primary care? And what does success look like for the patient rather than only for the transaction? Bahrain's example reminds us that health financing is never only a financial component. It shapes behavior, access, referral, accountability, and most importantly, trust. Kuwait's long-range frame is New Kuwait 2035. High-quality healthcare is one of its 7 national pillars, alongside governance, infrastructure, human capital, and economic priorities. Official policy material around that pillar has emphasized better quality, stronger public health capability, prevention of non-communicable disease, workforce development, governance, and sustainable financing. Kuwait has also said officially that it's executing a national health strategy under the wider development plan. However, a detailed public strategy document confirming its exact time horizon, pillars, and target scorecard isn't available at the moment, but we're going to keep monitoring it. That means the responsible approach is to assess visible programs on their own published commitments rather than fill the gap with just some assumed targets or goals. Those programs show several active directions: continued hospital and primary care capacity, stronger screening and community services, a more visible digital front door, updated expat insurance rules, and the continuing demand public-private insurance and delivery model. The Salem platform, launched in 2025 to replace the earlier health app, brings appointments, profiles, results, medicines, and preventative alerts into one singular portal. That can reduce friction for patients, but a unified portal shouldn't be confused with proof of complete interoperability across every single provider and every longitudinal record. The patient-level promise is near access, clear navigation, and more visible information. The system-level challenge is to connect large capital investment with primary care demand, management, workforce, financing, and accountable outcomes. For any proposed program in Kuwait, 4 details should be very explicit: the public outcome, the accountable owner, the implementation milestone, and the measure. A new facility, for example, may be an important input, but the question is, what does it change in terms of weighting, access, continuity, safety, or population health? Infrastructure is necessary. It's just not by itself a health outcome. It's an infrastructure. Kuwait's lesson is that a broad national pillar creates direction and permission. Visible delivery architecture, which includes owners, timelines, and measures, is what turns that direction into confidence and impact. When we place the 6 countries side by side, a common set of pressures becomes visible, which is what we see globally as well. Every system is trying to move further upstream towards prevention and earlier detection, along with things such as precision medicine. But every system is facing a challenge or a burden of non-communicable diseases, as an example. Every system needs a workforce able to know and operate new care models, not just simply give them more technology. Every system is asking how digital tools, data, and even AI can create value without weakening trust. And every system has to balance access, quality, resilience, and sustainable financing. The convergence here is absolutely real. The operating models are not identical. Saudi Arabia is undertaking a large structural redesign around clusters, integrated systems of care, and population accountability, whereas the UAE uses a federated portfolio in which national ambition, emirate regulation, and specialized initiatives can move at different speeds. Oman connects a long planning horizon to policy, 5-year cycles, and geographic equity. Qatar offers a particularly visible line from national vision to sector targets and provider plans. Bahrain's reform logic is strongly shaped by national insurance, purchaser-provider separation, and autonomous providers. And Kuwait combines a broad Vision 2035 health pillar with active capacity, primary care, digital governance, and financing programs whose public strategy detail varies. That comparison shouldn't become just a table. Each model reflects its own institution, population, choices, and stages of implementation. There is no right or wrong model. It's just a model that's used by that country. The useful discipline here is to ask what can be learned without pretending that one country's operating model can be just simply copied and tacked into another. There's also a new regional layer. Official GCC communications describe Gulf Health Action as operating within a Gulf Health strategy for 2026 to 2030, with ambitions around health security, longer lives, lower mortality, prevention of non-communicable diseases, research, innovation, AI and data, and the exchange of expertise. That certainly does not create just one GCC health system. It does, however, create a stronger basis for cooperation, where cross-border value is real for things like surveillance, preparedness and response, evidence, standards, selected data approaches, and shared learnings with best practices. The countries are not following just one blueprint. What they're doing is solving a shared set of pressures through different operating models and approaches. The regional opportunity is to make those differences a source of learning rather than just fragmentation. So let's think about this. How should a healthcare leader, innovator, or investor use these practices? I would actually apply 6 tests here. The first test, outcome. What population or patient outcome is the program expected to change? Name it before naming the technology or asset. The second test, the patient journey. Where does the person enter? What barrier disappears? How do they move between services, and what happens after the intervention? If the proposal improves one encounter, but fragments the rest of the journey, it's not aligned yet. The third test, accountability. Who sets the policy? Who regulates? Who purchases? Who delivers? And ultimately, who owns the result? Those may be different organizations. Ambiguity here becomes delay later. Test 4, equity. Which geography, income group, age group, workforce, or vulnerable population could be left behind? National averages can improve, while important gaps can still remain hidden. The fifth test, evidence and data. What is the baseline? What is the measure? What evidence threshold applies? And can the relevant information move safely across the pathway? A dashboard is not accountability unless someone is required to act on what it specifically shows and tells you. The sixth test, sustainability and capability. What will the program cost to operate? Who's going to staff it? What local capability will be built, and what happens after the pilot funding or launch attention ends? For an external partner, these tests can become a simple 6-line proposition. The public priority is this. The population is this. The barrier is this. Our intervention changes this part of the pathway. This is the measure. And this is the local owner and capability plan. That is what meaningful alignment looks like. Alignment isn't a national vision logo on the corner of a slide or a projector. It's a measurable contribution to a public outcome, delivered through the correct institutions in a way that patients can actually experience in their day-to-day lives. As we close, I invite you to look again at the health vision or strategy that shapes your own work. Ask 4 questions. Which layer of the vision am I using? Destination, route, delivery, or scorecard? What outcomes should change? What would a patient notice within the next 6 months, 12 months, 24 months? And who's accountable if that change does not happen? Across the GCC, the language is becoming more preventative, more personalized, more integrated, and certainly more digital and more focused on resilience. That's important. But the true measure will never be the ambition of just the document alone. It'll be whether a person receives care earlier, whether their information follows them, whether a clinician has the time, the tools, and the authority to make a better decision, a more personalized decision, whether financing rewards value, whether geography or circumstance becomes less decisive in determining access and quality, and whether the result is reported honestly enough for the system to learn from itself. A vision becomes real only when the patient experiences the difference. I would like to leave you with one question. What single measure would convince you that a national health vision is becoming daily reality? Thank you for joining me for episode 3 of Health Majlis, Conversation Shaping Healthcare Across the Middle East. I'm Dr. Paul Setlak, and I look forward to welcoming you to our next conversation.